Hello, everyone, and welcome to Positive Health. I'm Susan Cole from Phoenix Health Movement.
And I'm Denis Onyango from Africa Advocacy Foundation.
And this is the live broadcast series focused on HIV and the pressing issues affecting Black communities. And we're joined by two absolutely phenomenal guests in this episode. Our first guest is Winnie Ssanyu Sseruma, a globally renowned HIV activist, consultant, and community leader. For decades, Winnie has championed the voices of African communities affected by HIV, both in the UK and internationally. She works across Africa, supporting community health organisations, co-authored Our Stories Told by Us, and founded BHAMEN to help translate lessons from the HIV movement into wider health justice. And Winnie has been living with HIV for almost 40 years.
Our second guest is Dr. Harvey Kennedy-Pitt, the amazing Harvey. He's a global public health consultant, health equity strategist, and scholar advocate focused on advancing health equity for the sexual and gender minorities. He's got expertise in research, policy, and practice, and he drives systemic change to dismantle barriers to better health worldwide.
Amazing. Absolutely looking forward to chatting with our incredible guests. And lots has been happening in the world of HIV and health equity recently. Last week, I was on a panel at Chatham House with an incredible group of people, including Winnie Byanyima, talking about pandemic preparedness. And we know that inequalities have been driving pandemics, and people living with HIV and the HIV response really shows the impact of pandemics and the fact that systemic forms of disadvantage are really driving inequalities. And we've learned that from HIV, we've seen it in COVID, we saw it in Mpox. But something that often isn't discussed is how important community action is in fixing and helping with pandemics, particularly around information. Too often, communities are just brought in at the end as tick box exercises. However, when communities are driving the responses with trusted information, we're making a real impact. So thank you, Denis, for everything that you're doing at AAF in terms of HIV and wider inequalities and showing the power of community.
And so to you as well, you've done a lot, especially of late, trying to highlight the voices of marginalized communities. The work you're doing on Do It London, the videos are amazing and very, very professional. And so thank you for that.
Wonderful. Thank you. So shall we bring on our first guest? Let's bring on Winnie.
Hello.
Hi, Winnie.
Welcome.
Hi. Hi, Susan. Hi, Denis. Thank you for having me.
It's absolutely wonderful to have you on. So let's jump right in there with it, Winnie. You've been living with HIV for 38 years, is that right?
Yes, it feels like a lifetime.
And you've witnessed enormous changes in the HIV response. Looking back, what do you think are the most important lessons the wider health sector can learn from the HIV movement?
Well, there are lots of lessons. And I think where the HIV movement really has been concerned is that most of what we've learned along the way as we were dealing with HIV itself. And because, for instance, we are among the first cohort, think of people now who are aging with HIV. You know, we are still learning how to navigate that, not just as patients, but also doctors and researchers and, you know, anybody actually involved in the HIV movement. However, I feel like there are maybe 3 lessons I can touch on very quickly that I think are really important. Is that the meaningful involvement of people with lived experience in designing projects, in designing services, inputting into the services that are offered to that particular community. Nothing about us without us. That's how it's translated, basically. And the second, yeah, go on, Dennis.
Well,
No, carry on. Let's carry on, Winnie. Yeah.
And then the second one is that peers and, you know, people who support those living with HIV are the infrastructure, and, you know, and have to be employed as people who work in the sector and not just given volunteer expenses, because they are a huge support network to people living with HIV. And perhaps the third that I can think of is that advocacy goes hand in hand with services. You know, if there's nothing, you know, if something is not working, you know, in the service, advocate to change it right there and then do it. Don't wait. And I think that those are the 3 that I can think of.
Amazing. Thank you so much, Winnie. I think perhaps what we forgot to say is that Winnie is a fantastic trainer as well. So Winnie delivered a series of our My Health training for advocates across Europe. And she is very popular in a place in Italy called Tieste. I think she went there and delivered a master speech, and they're still asking for her 6 years down the line. So great. Yeah, but Winnie, I had to just ask, you know, you've long championed the importance of treatment information and health literacy. Why is it so important that Black communities have access to trusted and culturally relevant information about HIV treatment and care?
Well, for me, you know, on a personal level, treatment is how I got into HIV activism, and, you know, learned about it, you know, how it impacts the body, how it works with HIV. And I really do feel that where we are concerned as people living with HIV, treatment is life, basically. You know, if you don't know enough about treatment, how are you going to take it? So it's really important that people get the right information. Also, in terms of getting that information, many of us are from different countries where accessing health is very different from accessing health in the UK. And it's really important to make sure that people have the information they need, and they're not just told by the doctor what they need. They need that kind of support. Being able to have treatment information is not just about treatment. It's about taking it. It's about getting the social support you need around that. It's also, you know, sometimes about talking to people from Black communities in a language they understand. So to get somebody else to tell them perhaps in their first language, you know, and that can be extremely helpful. So there are lots of intricacies and nuances that are so important when people get treatment information. It's really more than just information.
Absolutely. I agree with you 100%. And I think particularly for people from Black communities where we face discrimination in healthcare settings, it's incredibly important for people to understand about treatment and also to know about their rights, because ultimately knowledge is power for people. So thank you so much for sharing that. And something that's very close to many of our hearts is Our Stories Told by Us, which celebrates the African contribution to the UK HIV response. The most incredible book. I would encourage everyone to pick it up from Amazon, Barnes and Nobles. I've written a little bit within it as well. But Winnie, thinking about that book, why is it so important for people from Black communities living with HIV to be telling their own stories?
Can I also add, by the way, thank you for the shout out about the book, but can I also add that we have now added a guided journal that people can actually use to be able to write their own stories or explore their own stories if they want. So that can also be acquired if they want. In terms of, the importance of telling our stories, it's really about reclaiming our agency, because we've lived with marginalization, not just as people living with HIV, but also Black people. So we really need to be able to reclaim our agency, and some of our stories have been erased. So we really have to be able to tell them, because they are no longer available. And then also to just correct the misrepresentation. There is a lot of misrepresentation out there in terms of what people living with HIV should be and should be not, and stereotypes. And I think lastly, stories that celebrate resilience, as resilient as we have been as people living with HIV, are really inspiring. And if people are able to tell their own stories, it's important that they tell them, so that we learn, for the future, and also for the young people who now don't have enough information about HIV.
Very true.
Amazing. Thank you, Winnie. So, we've come a long way, Winnie, with HIV treatment. People are now living, better life due to innovation that we're seeing in terms of treatment. But still, we see that a lot of people, especially those from marginalized communities or communities that are underserved by healthcare, still experience a lot of difficulties. So, as somebody who has lived with HIV for over 40 years, what advice would you give someone who's growing older with HIV and maybe experiencing some of these intersecting factors that impact people's health outcome? What would you tell somebody like that?
Well, as I indicated in the beginning, is that many of us are aging with HIV. And actually, if somebody who's maturing, can I say, with age, and I would say you are not alone. There are so many of us maturing with HIV, and I think the average age of a person living with HIV in the UK is about 53. So that is incredible, first of all, amazing, but it's also like almost surprising and shocking in the same breath. So many of us are aging with HIV. We didn't think we were going to get this old. And we are navigating this particular journey very slowly. We need the support. We need, we need to talk to others who are also doing this journey at the same time. So it's important for somebody to surround themselves with a group of friends who perhaps are in the same position, to share information, and to make sure that you stay engaged and know what to do. But also, most importantly, to take care of your own health, because there are so many other issues that you're dealing with around aging, but there are also other issues that you might face, like comorbidities, other illnesses, and to know how to navigate that. So to be able to go for the tests, vaccinations, mammograms if you're a woman, all sorts of things, so that you stay healthy, and that even if something is wrong or something appears, it can be identified very quickly, because you are attending your appointments with GPs, with your HIV physician. Yeah, but to really stay connected and to surround yourself with some sort of social support is really important.
Amazing.
Wonderful. Thank you so much, Winnie. And that is such important advice. And staying connected, getting support from peers, the importance of knowledge and information. You share such important advice and have been doing it for so many years, and you are such an inspiration to so many of us. So thank you for everything that you've done and continue to do, Winnie.
Thank you both for having me.
Thank
Take care.
you.
You're
See you
also
soon.
very inspiring.
Oh, thank you.
Thank you. You're so kind. Thank you so much, Winnie.
Absolutely. Such a joy always to speak with Winnie. But Denis, talking about inspirational people, now you did something really, really inspirational that I was at last week, and so was Harvey, bringing people together for a round table to talk about European health equity. So could you tell us some of the things that you found at your absolutely brilliant event, and really great food as well?
Oh, yeah. Thank you so much. And I think that was great that people, the quality of expertise we had around the table was great. So this was a health equity round table that was held in Central London at the Royal College of Surgeons. And it was basically to try and identify some practical based solutions to reduce health inequalities, especially for populations that are underserved. And so we're mainly focusing on HIV prevention, diagnosis, and care. But, we had like really good discussions, apart from getting an overview of the epidemiology across Europe from the ECDC and the HIV Action Plan in England. We also saw that the PrEP gap is still huge in Europe. So that was some of the presentations. But in terms of the discussions, we were focusing on, closing the prevention gap, looking at policy and legal barriers, how we can reform that, and also looking at sustainable funding. So there were good ideas around identifying very practical approaches. So we did have discussions on how to challenge some of the legal policy and legal issues that keep people from care, but also how to have sustainable funding models that can ensure that people who need the services are able to access them. So really great. And Harvey did the wonderful job of writing up the report. So you'll see it. It's wonderful.
Fantastic. Really looking forward to seeing the report. And it's so important to not only highlight the problems, because we've been living with these problems for so long, but actually seeing recommendations in terms of practical, tangible steps to actually end the inequalities that we're seeing, and having it led by communities, and also ensuring that communities are funded properly to be able to do this important work. So thank you so much for bringing everyone together for that. So shall we bring on our next guest, who was there? Dr. Harvey.
Hello.
Harvey. How are you?
I'm fine, thank you. Really pleased to be in the space with you.
It's absolutely wonderful to have you on, Harvey. So Harvey, your doctoral research explored the experiences of LGBTQ plus Black people accessing sexual health information and services. What were some of the key barriers that people told you that they faced?
Yeah, well, actually, it was really about how we optimize existing services because it's not about starting from scratch. It's about looking at why things aren't working as well and then trying to really ramp up their effectiveness. So that was kind of my focus. In terms of barriers, I came across things like intrapersonal barriers, the way that we think about ourselves as lived experience people, interpersonal barriers, how we engage with professionals or other people in our communities, but also more historical ones like structural barriers or even situational barriers. So what is your circumstance in terms of for immigration, for example, your situation, what situation are you in? How does that impact your ability to engage effectively with services? But also thinking about cultural barriers, which Winnie spoke about earlier on, that there are differences in the way that individuals are experiencing things and how they view things, and they're informed largely by who they are and who they've been raised to be. And so all of these barriers kind of intersecting and creating people's perceptions of their health beliefs around how they engage with sexual health services, and of course the health outcomes associated with that. So those are a couple of barriers.
Amazing, amazing. And being the solution-oriented guy that you are,
Absolutely.
as I love about you, always want to say we are tired of this solution. So yeah, being the solution-oriented guy that you are, so in response to those findings, you developed the OSHARM model, which is optimizing sexual health access for sexual minorities. Can you tell us what it is and how you use it in your daily work every day?
Yeah, more than just being bored of hearing about the barriers, it's about building upon the barriers. So the barriers are really important to understand, and they should remain a main part of the conversation. But as we build towards solutions, how do those barriers map across to the solutions that we need? That's what we're interested in. And so OSHARM, which of course you've said is the Optimizing Sexual Health Access for Racial Sexual Minorities model, I was really interested in understanding what was required for services to be optimal. So working with my study participants, we sort of use something called mutual construction to design this model. First of all, the information that we have, where does it come from? Is it credible? Can I use it? We're thinking about autonomy now, because if we just hold information and we don't share with communities, they can't effectively make those decisions. So I wanted to know, well, what do you need in terms of information in order to be able to be more autonomous in your decision making? Secondly, historically, we believe, well, you're Kenyan and I'm Kenyan, so perfect. I can just put you in a room with a Kenyan doctor if you're Kenyan, and you're going to have an amazing experience. But actually, what the research highlighted was that person has to both have maybe lived experience, but most importantly, competency in their work, to be good at their job, to understand all the dynamics, because we have people who maybe lived experienced people, but they're not lived through experienced people. So they have never actually lived through that thing, but they just get identified or grouped as someone who must have lived experience of that thing, which is not accurate according to this research. And then finally, also thinking about the environment. So creating safe, sensitive, and inclusive environments was really critical to the study participants, because essentially you could have everything else right, and if you walk into that facility or into that service or that event, and you're not feeling welcome, the signs around the room don't represent you, they make you feel uncomfortable, the way that people engage with you makes you feel unsafe, that can't be an optimal experience for you. So it was brought together in an intersectional way, 3 circles kind of merging into one, as a suggested practical health equity-centered model that people can actually use to really improve the existing services they have without having to start from scratch, which sounds like a really expensive choice to have to make.
Yeah. Absolutely, it would be really expensive to start from scratch, but I think what you found, I think, is something that is really tangible that people can be moving forward with. And I think the intersectional lens is so important, and healthcare professionals just really need to be so much more aware of that. But if we could think about one of the really big challenges of our time at the moment, it's the really shocking anti-migrant rhetoric that's really prevalent at the moment. We're seeing it here in the UK, we're seeing it in Europe, we're seeing it in the US and more widely. And here in the UK, the Reform Party have been suggesting that if they were in power, asylum seekers with HIV wouldn't be allowed to have treatment. As a as someone who works in public health, how can we harness public health messaging to challenge these narratives more effectively than we're doing at the moment?
Well, public health is one of the fields that is least understood and very poorly engaged with because people can't define it. So I think it's important to start with what it actually is. And it is designed to promote health and to prevent disease and to prolong life. And if we aren't doing those three things, then we're pouring money and resource into something that's not going to work. It's not going to do what it says on the tin. And one of the greatest things about public health is that it's designed to be data-led. It's not about guessing, it's not about opinions, it's not about giving insight from solely lived experience in isolation. It's about saying, okay, those things are important, but what does the data say? And a lot of the political decisions that we're seeing being made do not align very well with what the data is telling us in terms of where the problem lies, where investment isn't working and should be maybe reallocated. And so it's very much rooted in opinion and people's feelings, and oftentimes historical feelings, maybe that were given to them by grandparents or parents. And so you'll see a lot of interviews emerging now with people in very right-wing protests. Well, why are you here today? Young men, children even, why are you here? And they can't tell you why they're there. All they know is that they wanted to do the right thing, to save England, to kind of, make the neighborhood safer. But they have no data or insight to explain why they're actually taking those actions. And so what public health has a unique role of doing is reminding people about the importance of data. Data isn't something really fancy that you have to do loads of really calculations. Everything is data. This conversation, when we end it today, will be data. It will be a data set that someone could look at and draw conclusions from. And so we have to really be careful on how complex or how distant we make public health to the general public, because actually public health is for everyone. And so the advice there would really be about, don't be afraid of the data. Look for the data. If there's a gap, call it the gap that it is, and then find some investment to find out how we can answer the questions that we have about that gap. Don't guess, because when we guess, lives are put at stake.
Very powerful, very, very powerful. That's Harvey. So in terms of just in terms of your research and experience working as a consultant, what do you think is the single most important lesson that health services can learn if they want to better support Black communities living with HIV?
I guess it's building on some of the research I've just shared very briefly. And there are sort of three values that I operate by now. The first one is everything that we do has to be person-centered. People have to be at the center of what we're doing, because health is only something that we can hold as people. Health is not something that you can box and put on the shelf. So it involves us, so that we have to be at the center of it. Secondly, I spoke about autonomy earlier on as well. And so when it comes to autonomy, the only way to make people autonomous or enable them to be autonomous is to give them the tools. If there are tools that have been developed, if there are means and ways and methods and strategies that we know exist, those need to be in the hands of the people that need to use them. So if we're hanging on to them, or we're trying to monetize them, or we're trying to keep them close to our chest, we are actually part of the problem. So we've got to give people the tools. And the third thing is really about creating the conditions. That speaks to the environment piece that I spoke about earlier on. And so really about ensuring that once I've centered you, once I've given you the tools, have I actually set you up to win? Have I created an environment for you to be as successful as you need to be? And so those are the three kind of values that I'm living by and working by in my own consultancy with Unstuck, because we've got to make it practical. We've got to keep it health equity centered, and it has to be rooted in data. And those three values were built out of the data I found in my own research.
Amazing. Thank you so much, Harvey. And I'm going to be embracing data much more closely now. And thanks for all the data that you have produced that's helping us in terms of messaging and doing better work where it comes to health equity. So thanks so much for coming on the show, Harvey.
Very welcome. My pleasure.
Wonderful to have you on.
Thank you, Harvey.
And Denis, I think we have run out of time, just about. I mean, such powerful and important conversation that we've been having. So yeah, I'd like to thank everyone for joining us today. I really hope you've enjoyed the show.
And thank you, Winnie and Harvey, for coming on the show. You are brilliant, brilliant.
Absolutely brilliant. And I'd like to thank the absolutely amazing Disruptive Live for their technical wizardry in making all of this possible. So if you have enjoyed Positive Health, you can watch all of the episodes on the Phoenix Health Movement YouTube channel. I've been told to encourage you, please subscribe to the channel, please like the show, share it with your friends and family and neighbors. Let's get the message out there, and we will be back next month with another episode of Positive Health. So hope to see you then. Thanks very much. Bye-bye.
Thank you, everyone. Bye-bye.